All right. Welcome back to Research Unpacked from the VALD Performance podcast. My name is Dylan Carmody, and I'm a physical therapist and strength and conditioning coach from the U.S. On today's show, we have Brady Green, and we will be diving into all things calf muscle strain injury as we unpack his paper, The Assessment, Management, and Prevention of Calf Muscle Strain Injuries, a qualitative study of the practices and perspectives of 20 expert sports clinicians. Brady, how you doing?
Yeah, very well. Thank you very much for having me, Dylan.
Of course. I am selfishly very excited for this conversation just because calf muscle strain injuries just tend to be this kind of black hole area, at least personally in my brain, as well as I feel like clinically for a lot of other individuals. So I think this will be a super awesome conversation. But before we get things started, maybe if you wouldn't mind giving the listeners just a brief introduction to you and your background.
Yeah, great. Thank you. So, I guess in terms of my academic background, I undertook an undergraduate degree in physiotherapy through La Trobe University. After completing that, I actually undertook a master's in strength and conditioning through Edith Cowan University, and then became more sort of involved in research and teaching at La Trobe, that led me to do my PhD. That really we were interested in investigating this black hole, these calf muscle strain injuries. And my PhD was really focused on assessment, management, and prevention. While I was undertaking that, we were also able to complete a few projects in the hamstring space, which was really good. So that's sort of my academic background, I guess. I will also mention that, currently I'm in an academic role at the University of Notre Dame in Fremantle, Australia. And so in terms of my clinical background, while I was undertaking my PhD, I was working in elite sport at the Essendon Football Club. And that was a really nice partnership, I guess, between being in the trenches at the coalface while conducting these studies that you'll hear about. And then, was at Essendon until halfway through last year.
Seems like quite the eclectic background, and I honestly find it pretty interesting that you went to the undergraduate degree in physio and then went to a master's in strength and conditioning. What was it that prompted the transition to S&C from physio?
Yeah, great question. So I think myself and colleagues really identified some shortcomings, potentially just in our understanding even, or not understanding, but potentially implementing rehabilitation practices across the whole spectrum of strength and conditioning activities. And I really wanted to develop my knowledge within that space. Just in terms of history, I think at the time when I did my undergraduate, we're really well versed in, potentially some lower load exercise, some more motor control biased exercise and rehabilitation. But I was really interested in how we could, do higher load activities, implement plyometrics, how conditioning fit in within the rehab process, really gearing it towards preparing people for a higher level of performance. So after doing some sort of research and things, identified that the S&C program at ECU was a really good program to develop my knowledge within that space. And certainly the learnings from that S&C Masters have held me in really great stead for designing, implementing rehab to prepare for performance at a high level of athletic output.
Yeah, I always feel like the best rehab providers, maybe it's a bias because I also come from an S&C background, but I feel like the providers that I tend to resonate the most with, that I feel like have a really good grasp of the entire continuum from injury to return to sport. They are always individuals that have some type of a background within the strength and conditioning realm or sector, just because it is truly difficult to understand and appreciate the loads that these athletes are undertaking on a daily basis without actually living it and experiencing it and seeing it day to day. And so I just feel like it's such an important aspect of the development of any, even if you decide to just stay with becoming a rehab provider. I think it's just an important aspect.
Yeah, that's really well said. And that continuum model, or the continuum perspective of what we're doing within a rehab process, we'll talk about this a lot in the calf space. But one of the key learnings that S&C or physio practitioners with experience in this area always talk about, and Phil Glasgow comes to mind, beginning with the end goal in mind and working backwards from that, and undertaking a needs analysis of what will be required. So I guess, part of me doing the S&C Masters was equipping myself to better understand those needs and then reverse engineer rehab from that to make it as specific and likely to be effective.
Totally. Applying the S&C principles to practice. And I think that's one of the reasons why I actually wanted to bring you on today, just because I had shared your guys' paper a couple times through social media, and was probably quite annoying about how I was talking about how it was probably one of the best papers that I'd read in the last year or two.
Oh, thank you.
Just from a perspective of how well everything was outlined, in terms of just like what you're talking about, the reverse engineering of a rehab plan, of a process, understanding what an individual's terminal task is, or beginning with the end in mind, right? Can you just start off by talking about this paper, and just maybe from your perspective, what gap do you feel like this paper filled in the research?
Yeah, great question. So I guess historically, our early projects were really targeted around identifying risk factors for injury, and then from a better understanding of risk factors, trying to improve what we do in clinical practice to prevent calf strains from occurring. But at face value, if you look at our systematic review of risk factors for calf injuries compared to, say, our systematic review of risk factors for hamstring strains, there's 11 versus 79 papers included within those systematic reviews. So it's pretty apparent that there's a significant limitation of the research undertaken in the calf space. And that really led us to undertake a qualitative study, where we had the opportunity to ask expert clinician researchers, practitioners working in sport, about all things calf, so that we could better understand why these injuries are occurring and hopefully have a better ability to prevent and manage them. So from the perspective of etiology, there was a really clear link between a limitation in our understanding and doing the qual paper. The other thing I wanted to mention too was that within my PhD, we were able to do some nice work evaluating the data from the AFL and the soft tissue registry of the AFL, and do things like, report on the epidemiology of calf strains and also prognosis for return to play and recurrence. But again, that's only within the AFL, and we understand that calf injuries affect terrestrial athletes from terrestrial sports, and so from that perspective, we really wanted breadth in the practitioners that we spoke to within the qualitative paper, where we highlighted or identified practitioners working across sports. So track and field, soccer, rugby, cricket, and with that breadth in mind, we feel that the paper was really well positioned to give us a much more detailed understanding of etiology.
100%. And I think that it is helpful to kind of create this background in terms of, a lot of times when we read papers, a lot of the listeners that we have are probably going to be familiar with certain things like randomization procedures or statistics or other methods of quantitative research, right? But this was not that paper, right? We were talking about qualitative research, and we're talking about interviews. Can we maybe discuss like the basics behind qualitative research to bring some of the listeners up to speed?
Yeah, great question. And I guess at the heart of why we chose to do a qualitative project is that, we really recognized that we were interested in nuance, and identifying themes and identifying emerging trends in practice from clinicians at the coalface. And I guess trying to capture colourful data that tells a story, that clearly you can't get from just raw statistics and raw numbers. And so I guess what I'm talking about is first establishing these clinicians' lived experiences of calf injuries, their perspectives, what they've found historically has worked and hasn't worked, and undertaking a thematic analysis of those experiences to identify, what might be important and what we might need to sort of target in future research as well. So fundamentally, I think really we were trying to identify the story about calf injuries in a way that you can't do if you're just undertaking statistical analysis with a quantitative method.
Definitely. And I think it helps to open up the idea, and it expands your bandwidth for what you are, I guess, allowed to discuss within the paper, right? Because I think a lot of times people will try to poke holes on quantitative researchers in terms of saying that they're trying to take too much from a single data set, right? Extrapolate too many different variables. Whereas I think a lot of times with qualitative research, you're just interpreting based on what these experts are telling you. And so that kind of opens up a lot of different opportunities.
Yeah, exactly. And that's part of the premise of why we did the paper. You've described that really well, Dylan. And I will mention too that within the interviews, they were semi-structured. So we had a series of questions that we knew that we would ask all experts, but then certainly we leveraged each expert's, specific knowledge and experiences, the learnings that they were offering, to really launch into those areas where we could. And that just provided another layer of information that you otherwise don't get if you're too sort of rigid or you're constrained to just quantitative analysis.
Definitely. Now, trying to maybe reel things back in and focus a little bit more on calf muscle strain injuries. Diving straight in, can we just talk about some of the structural differences between, calf musculature and maybe other lower extremity muscles, like the quads or the hamstrings, that may influence the calf's, mechanism of injury or rehab or return to play?
Yeah, great. So, at face value, with the calf itself, given its unique structure and function, and even some of the key differences between soleus and gastrocnemius, we're not always comparing apples with apples when we talk calf structure, function, and injury compared to hamstring or quadriceps structure, function, and injury. I think the calf is a different beast. Fundamentally, you've got these two muscles, the highly fast twitch gastrocnemius, and obviously the deepest soleus, and soleus itself has somewhat complex architecture with its intramuscular connective tissues, which they've been highlighted for their sort of role as injury locations, and injuries extending to involve those connective tissue structures within soleus could be, or seems to be an important thing for understanding prognosis. But also, it really highlights the function of the soleus, and how this soleus, while it's, primarily a slow twitch muscle in terms of fiber prevalence, of our slow twitch versus our fast twitch fibers, it's also a heavily power producing muscle, and it really needs that power endurance in order to produce really large peak forces when people are running and jumping and accelerating. So I think previously it was quite poorly understood in terms of the role that soleus played in function. And, I remember back to my undergraduate days where soleus was really described to us as this highly slow twitch postural muscle that really did very little other than helping to keep our body upright. But we know that's not the case. We know that it has, the largest physiological cross-sectional area of the lower limb muscles, and clearly a large physiological cross-sectional area is going to be related to very high peak force generating capacity, which again is tied to those peak force generating requirements that I've mentioned. And so moving away from soleus, considering the gastrocnemius, obviously with our medial and our lateral heads, and an emerging area with our understanding of gastrocnemius is the way that those distal fibers insert into that distal area of connective tissue, that then also becomes a discrete zone of connective tissue called the gastrocnemius runout. And that could be an important area in terms of prognosis for return to play and recurrence as well. And it at least seems to be, from Carlos Pedret's preliminary work, his paper published in the Scandinavian Journal of Medicine and Science in Sports. So I feel like I've talked through a few factors there, but I guess the main clinical takeaway is that we aren't always comparing apples with apples in terms of calf structure and function compared to other commonly injured lower limb muscles. But then within the calf, soleus versus gastrocnemius, fundamentally they have different structure and function as well. And we probably need to approach prevention and management of soleus and gastrocnemius injuries slightly differently.
Recently, or at least recently to me, I have come across a couple papers that reference this kind of coiling of like the subtendons within the calf complex. Do you have any maybe hypotheses or understandings as to what kind of advantages that may help with us as humans?
Yeah, so in terms of these connective tissues within the calf, if we pull it back to a really simplistic understanding of the calf muscle tendon unit with our contractile elements and our elastic elements that are in series with those, really leaning on the Hill model of a muscle tendon unit. Clearly the structure and integrity of connective tissue structures that are in series with the contractile elements, so those being our intramuscular aponeuroses and also our Achilles free tendon, the patency integrity of those connective tissue structures is really important for the ability of the muscle to undergo a good stretch shortening cycle. Understanding that within those series elastic elements, we're going to have an element of elastic energy storage and release. And so in terms of tissue integrity, I think it's really important that those structures do have optimal integrity to be able to support and participate in a stretch shortening cycle, like we encounter in running, changing direction, accelerating, and so forth. So from that perspective, I think that, we do need to consider the structure of these intramuscular connective tissues and doing, prevention practices that develop really good tissue patency as well.
Yeah, I couldn't agree more. Transitioning a little bit here, let's put ourselves in the expert's shoes a little bit, right? So let's say you, Brady Green, the physio, has an athlete coming in and they're very vague in their description. And they just say they're reporting pain in their calf from their sport. According to your paper, what does an expert calf examination look like?
Yeah, okay. So I think if we start subjectively, taking a detailed patient history is fundamental to our diagnosis and our differential diagnosis. So I'd really be keen to understand the onset of that pain. Was there an inciting mechanism or not? It seems pretty apparent from the qual paper and also from our analysis of AFL data that soleus injuries, about half of those, actually lack a specific inciting mechanism, which can be difficult for clinicians to understand in that, historically, patients will always tell us when they've strained their hamstring or they've strained their rectus femoris or their adductor longus, but we don't necessarily always have that history of an instantaneous insult that has resulted in a soleus strain. And certainly as well, it's more common for our gastrocnemius injuries to have that specific inciting mechanism. So I'd be really trying to establish that history of pain or symptom onset. I would then be trying to establish the level of impairment immediately. So, is this a situation where the patient is having difficulty just with simple walking and simple activities of daily living, e.g. they have an antalgic gait and they're limping around and sort of can't tolerate any weight-bearing dorsiflexion at all? Or is this a situation where the athlete or person actually needs to do something more high load to elicit their symptoms, such as jogging or running or jumping? And that would give you a preliminary interpretation of severity, where clearly, the first scenario I described, the person that is having trouble with simple activities of daily living, that's going to lead us to think that the pathology is perhaps more significant. So history of onset, level of impairment, and then location as well. Often soleus-based presentations can result in more diffuse symptoms and more, pain or symptoms that aren't as easily focal to one location. Don't get me wrong, they can result in very focal symptoms, but there are the subset that isn't the case, that we need to be mindful of as clinicians as well. Historically, gastrocnemius-based injuries, they are more focal, and patients or athletes will be able to pretty reliably point to or describe the location of their issue, certainly to an extent that you're more confident compared to some of our soleus-based pathology. So really to this point, in terms of our history taking, we've established the history of onset, the level of impairment, the location. And then I'd also be interested in precipitating factors prior to this, this injury episode. So does the patient have anything in their history that predisposed them to the calf strain, which could be related to their own injury history? It could be related to sort of their intrinsic information, such as being an older athlete or an older patient, where we understand that could increase his susceptibility to a calf strain and make a calf strain diagnosis more likely. In terms of injury history, what you need to tease out as a clinician is the history of calf strains bilaterally, and that will give you an impression of the likelihood that they've sustained a calf strain in this instance, but then also potentially how conservative you might need to be in their management to ensure that they don't have a recurrence. And within the recurrence arm as well, we need to ask about a history of ankle injury. Certainly from the AFL data, we identified that having a history of an ankle joint injury predisposed to an early recurrence. And so if we want to avoid our patient or our athlete sustaining a recurrence early, e.g. within the first 6 to 8 weeks of their rehab process, we might need to put things in place if they do have that significant ankle injury history. So I guess those 4 themes I've identified in terms of history taking, mechanism of onset, level of impairment, location of pain, and then presence of predisposing factors. And from that, we'll have a really clear understanding of the likely diagnosis and grading before we then jump into our objective or physical assessment. And with physical assessment, a really nice algorithm that we've been working with is the look, feel, and move. Okay, so looking at your patient initially passively, observing whether they're adopting an antalgic posture to offload the calf as an indication of severity, where with more significant calf strains, they'll certainly passively try and offload that injured structure. You want to observe for differences in relative calf bulk. And certainly the patients that have that more extensive history of recurrences and previous calf strains, or even previous ankle injuries, they might have a atrophy or a relative difference in bulk that would represent a reduction in the force generating capacity of the calf. So you want to pick that up at baseline as well. In terms of observation, you would also observe for obvious signs of injury. Okay, so is there swelling or bruising present that's visible? And in cases of superficial injuries, is there actual a visual defect, which at times you can see in, say, medial gastrocnemius ruptures? And then moving from passive observation, you would do a quick active observation really as a screening to identify location and severity, where you might ask the patient to do some simple functional activities, such as simple walking, squatting based activities, and you might also ask them to do a calf raising battery if it was appropriate based on the level of impairment that you identified with their walking and their squatting. Clearly, if they're limping around, they're having significant difficulty just with simple walking, they mightn't have the capacity to go through a battery of calf raise tests. So you do need to match that with what you're seeing in your patient in real time. Within the calf raise battery, so a really simple process that I'd work through would be starting simply bilaterally. Okay, so two-leg calf raising, checking for A, capacity to do the two-leg calf raise, but then B, the quality of movement and the presence of symptoms. And then if they can be bilaterally calf raising, can they go up with two and down with one? Okay, so bilateral concentric, single leg eccentric, and then you would quickly check a single leg calf raise. Okay, do they have the capacity to do it, and are we eliciting symptoms? And then from there, you would move into the feel part of the physical examination, where within feel, it's all about palpation findings, okay, and undertaking a detailed palpatory assessment. And certainly the evidence suggests that we need to do things like identify the location of symptoms, and then track the length of tenderness as well. Where more extensive injuries, it appears that you might identify higher pain scores, but then more extensive length of tenderness as well, compared to more lower grade strains and subtle injuries, and particularly more subtle injuries involving, say, our deepest soleus, where you mightn't actually have as clear of an ability to identify the location of the injury at times. But certainly there are many instances where you can with your palpation. Part of why that palpatory assessment is important is that within a rehab, you can then track the resolution of palpation tenderness as an outcome measure, and if that is resolving at the rate that you would expect. And then from that part of the physical examination, you would then do functional assessment. Okay, so the move part of the assessment, where you're really trying to identify the threshold for symptom onset. Okay, so if it isn't already clear from the quick functional screen where the patient's at in terms of their calf capacity, you can move from doing the calf raise battery into simple plyometric tasks initially, which might be bilateral in nature, e.g. simple two-leg hopping on the spot, into single leg hopping, into doing a running or a jogging type assessment, where, when you move through those quick functional tests, you stop at the point that you have identified symptoms. You don't progress through and do a provocative type assessment, potentially making the injury worse. You're really just interested in where the patient's at in terms of their capacity, and then that will give you an understanding of the likely injury grade as well, before we do things like undertake imaging investigations if we have scope to do that, or if we think it's worthwhile. So I've said a fair bit there, I'm mindful, Dylan, but I think that's the nuts and bolts of the key things to do for calf injury diagnosis. Actually, I failed to mention stretch tests. So we also want to have a look at tissue length and extensibility in straight knee and bent knee positions, so that we can be confident that we've done palpation, contraction, and stretch, with the theory being, soleus-based pathology will be more sensitive to bent knee testing positions, whereas gastrocnemius pathology will be more sensitive to positions where the knee's extended and the ankle's dorsiflexed. And then as a side comment as well, there are clearly elements of the differential diagnosis and tests that we might consider doing if we're thinking that a calf strain diagnosis is less likely.
Brady, that was perfect. That's enough information for the entire podcast if we want to just call it there. But no, that was great in terms of just giving a really solid foundation and background for the listeners in terms of what expert clinicians see as being, go-to tests and measures. One thing that you had referenced was the idea of just making sure that the calf raise was consistent, or making sure that the individuals were able to perform a calf raise, whether that be pain-free or not. Do you have any, heuristics or ways about making sure that the calf raises from a qualitative perspective are consistent, whether that be technique-based factors or height-based factors, to make sure that they're getting consistently as high each time? Are there certain things that you're considering within the specifics of, qualifying a calf raise?
Yeah, great question. And if we talk about this in terms of clinical assessment for diagnosis initially, and then we can talk about when you're testing the calf raise throughout a rehab process or for prevention. So I think diagnostically, setting the patient up the same way every time is really, really important for the reproducibility of your testing, because certainly in conjunction with your palpation findings, you would track calf raise capacity serially across a rehabilitation process and really observe and measure their capacity improve over time to give you a really good understanding of their rate of progression and their eventual prognosis, irrespective of what you've thought at baseline. But in terms of really simple, a simple clinical method, I just set the patient up at the wall with fingertips at shoulder height, and initially test it with the knees extended, followed by with the knees flexed, with the theory being that gastrocnemius injuries will be more sensitive to positions of knee extension versus soleus positions of knee flexion, due to the anatomy of the muscles. But also understand that soleus doesn't always follow the same rules, and sometimes soleus-based pathology will be more sensitive to knee extended positions. But you would really talk to your patient about trying to rise up as high as they can over the course of 1 second, okay, getting to their max height, and then also lowering with control over the course of 1 second. So part of why you do that is that you're really controlling the loading rate. to ensure that your patient is using their contractile elements, so their muscle fibers to do the work, and they're not using compensations, involving their elastic tissues and so forth, just to sort of bounce through the test passively. And while you're doing that test as well, you're instructing the patient to inform you when they have any symptoms, point out to you the location of those symptoms, and then the intensity, okay, as a score out of 10 of those symptoms when they come on. And really that information will give us a really detailed understanding of the capacity of the patient in terms of their weight-bearing plantar flexion, which, keeping our end goal in mind, in terms of what the calf has to do right at the end, is do weight-bearing plantar flexion at a very, very high level, okay? So this is like our elementary look at it, if you will. Now, if I sort of transition to talking about as a rehab marker, and not so much in terms of diagnosis, fundamentally, the setup will be similar, okay? Positioning the patient at the wall with fingertips at shoulder height. And my preference is initially to build out stock standard body weight strength endurance with the knee extended as a strength endurance marker of capacity to repeatedly generate force over time. Understanding that while the knee is extended, we still will get significant soleus contribution to the work. It's not as though because the knee's extended, it's just gastrocs. We still get lots and lots of soleus contribution. So at the wall, fingertips at shoulder height, trunk vertical, with the knee maintained in extension, ensuring that as the patient does the calf raise, okay, they're not rocking their trunk backwards and forwards. They're not bending their knee or flexing their knee. They're not hitching with their hip and getting propulsion from their proximal muscles. And then their mechanics at the foot and ankle are really important too. Okay, so ensuring the axis of plantar flexion is occurring along the line of the second, okay, where we're not heavy into the first, which will lead to sort of pronation type mechanics. We're also not too heavy laterally into the fourth and the fifth, where that can result in things like sickling as your patient does the plantar flexion. In patients with stubborn mechanics that you can't correct, you might want to draw on their foot along the line of their second as a bit of a visual cue for them to do that plantar flexion along the axes there. And then the final thing I want to mention is that you actually provide auditory feedback in the form of a metronome to time the loading rate at 60 beats per minute we've been working with in the research space and clinically as well. And that certainly leverages the really good work from Kim, Hebert, Lozier and others developing calf raise protocols. And so that would just be a simple process of downloading a metronome for, an iPhone or a smartphone or another device, and actually playing that to the patient while they do the calf raise. So controlling that 1 second up, 1 second down, going for max height, and ensuring that they adhere to that. So I think I've covered off on a few key points there related to standardizing your testing for diagnosis, as well as standardizing how the calf raise is performed within your rehab progressions to get that really, really high degree of repeated force generating capacity, we'll call it.
Yeah. So Brady, let's maybe fast forward a bit, right? And so now we're actually doing the thing, right? We're rehabbing this injury to try and get back to whatever that individual's terminal task is. However, let's talk about some of the common themes that the rehabilitation principles or the experts uncovered about these rehabilitation principles that were central to really high quality calf rehabilitation.
Great. Yep. So I guess if we begin broadly, within a calf rehab, because the terminal goal or the terminal point we're trying to get to is this essentially power endurance capacity of the calf, okay? This high end function repeatedly over time, which for many athletes or patients might mean that they need to run for a 1 hour match or a 2 hour match and not break down. So really this power endurance is a mixed quality. It's not, say, pure strength or pure endurance or pure power, for argument's sake. And so that means that within our rehab, we need to be doing things across the various mixed qualities that contribute to an ability to have power endurance. So what I mean by that is that we need an exercise thread related to strength endurance, okay, body weight strength endurance for just repeated force generating capacity and endurance with that against our body weight. We also need a higher end repeated force output, okay, so loaded strength endurance. And we need to be doing good isotonic strengthening through range, both in bent knee and straight knee position, utilizing things like a Smith machine or a good seated calf raise machine to develop that isotonic capacity. Those exercises really lend themselves to strengthening through range across a rehab as well. Initially starting just to plantar neutral, but as the patient improves, gets stronger, gets better eccentric capacity, actually going into max dorsiflexion where you can is important. And so we've gone identifying that, we need this body weight strength endurance, we need loaded strength endurance. It's unavoidable that we also need just max brute force generating capacity, okay, within the calf. And I mentioned earlier that the calf needs to produce and moderate really high peak forces. And I think Kev Lieberthal and Craig Purdom described this really well, where even running at relatively elementary speeds, your soleus encounters peak forces of 6 to 8 times your body weight, and the forces going through the whole calf muscle tendon unit and your Achilles can be in the vicinity of 10 to 12 times your body weight. So we do need that ability to just generate brute peak force. And I think, some really good isometric strengthening and building that out within a rehab to get that isometric force generating capacity really, really high will support our calf function in that regard. And then from there, we also have our loaded power, okay, where we're starting to think about the rate that the work is done and the speed with which we can actually develop or produce force, that explosivity. And I think it's critical to be doing exercises to develop, our power output, both through range and also isometrically. Okay, so, pushing load through range quickly, doing things like prowler and sled, resisted work against bands, pushing sort of through range, forwards through space is really important. But then we can also do nice exercise selection, getting that instantaneous rate of force development, say in the Smith machine, doing isometric switches or, the switch catches against a load. Again, that isn't super heavy, where the only challenge is just force production. It's more that middle ground where we're getting good force production, but there's also the velocity component. And the athlete has to do things like maintain their heel height against that load versus let the heel drop when they encounter that load. And then the next arm is really the stretch shortening cycle, okay? Plyometric capacity and elastic function. And at face value, we can consider these exercises in terms of developing our vertical competency, our vertical output, as well as our horizontal component. And we should be prescribing both vertical and horizontal plyos, where the next layer down is to prescribe plyos that are about, maximum outputs for a short period of time, but also the repeatability piece, where the outputs are more submaximal, but we might be asking someone to do those repeatedly for a duration or for a distance. And so part of why that's important clinically is that, again, we're getting the brute power and the brute output, but we're also getting the endurance piece. And so where we've got to in the end across all of those arms of rehab is that I think we're in a really good position to have that end goal of power endurance. And the final, thing I want to say is that within a really good rehab process, like we identify within the study, each of these rehab arms or streams are overlapping. So it's not a scenario where, we tick off, say, strength, and then we don't do any strengthening subsequently because we've ticked it off. We actually keep the strength thread underpinning and throughout the whole rehab process. And likewise, when we integrate a bit of that loaded power work, it stays within the program, but we're just smart about where we program it around where, say, the athlete or the patient is doing their running and their field-based rehabilitation, so that we're not compromising them in terms of fatigue or getting any interference. A few things there, Dylan, but I think I've sort of covered the key points.
Yeah, definitely. And I really appreciate just the entire breadth of what you're talking about, like the entirety of this rehab process, right? However, I think that you had mentioned around somewhere halfway through the idea behind horizontal and vertical plyometrics.
Great.
Are there some nuances between there that we could dive into? Are there certain forces that are better tolerated early on versus later on? How do you go about kind of dosing in those directions of forces?
Yeah, great question. And so back a step two, with your strengthening processes and those strengthening threads, you should incorporate a degree of vertical and horizontal strengthening where you can from the outset. And we know that once a horizontal component is introduced, particularly with our plyometric work, there'll be greater lengthening and stiffness demands imposed upon the calf MTU or muscle tendon unit. So really, if we start from strengthening, getting both vertical and horizontal capacity, and then map that out to include that within our plyos, we're, in my opinion, adequately preparing the calf, versus historically, lots of the calf strengthening is just vertical. It's all just pushing upwards and that's it, which is, perhaps only addressing part of the problem. What I want to mention too with the horizontal component is where locomotive reconditioning fits between isotonic strengthening and our plyos. Okay, so what I'm talking about in terms of locomotive reconditioning is, getting the prowler out, getting the sled out, and sort of pushing through range against forces with our calf muscles working through range as well, needing to lengthen, needing to shorten while, we're propelling the body forwards, is fundamental to preparing the calf for that before it will then face it during plyometrics and running. And so that's a key takeaway as well. Make sure you're integrating prowler and sled, even, stair climbs or hill walks or lunge walks up hills, stuff like that, can be really useful too. And then within the plyometric arm, we have sort of our true plyometrics, I guess. But then we also have things like our run drills, which, like A walking, lunge walking, arabesque walking, where there isn't quite the true plyometric component just yet because there isn't energy storage and release. But it's certainly a functional movement through space where, again, we are getting a bit of lengthening and shortening of the healing calf that is important to developing that horizontal component. With the plyometric prescriptions, so we've got there, Dylan, with a bit of background beforehand, but I think that is important. With the plyometric prescriptions, for the reasons I mentioned at the start, where as soon as we do introduce a forward or a horizontal element, there is greater lengthening and stiffness demands imposed upon the muscle tendon unit. It's perhaps better to initially develop that vertical capacity and then progressively introduce the horizontal component when the patient has shown you that they do have that vertical capacity.
Definitely. And I think the elaboration that you gave in terms of a big heuristic, I guess, that I like to follow is, like the first time you do something shouldn't be the first time that you really do something. And so the idea that you're kind of touching on here is like working on these almost like quasi plyometrics, right? You have the A drills, you have B drills, you have different skippings or things like that you can slowly start to titrate in so that once you begin plyometric training, you're ready to go.
100%, yeah. And sorry, mate, one thing I want to say about that as well is that if you're drip feeding some of these rehab activities into an interwoven rehab plan, you actually get, clinical assessment happening while you're observing the patient do it before they're potentially in a situation where they might re-injure. So clinically, I've been in instances where a patient's developing their strength really well, but then you watch them do some very low level run drills, and their actual control and their movement, they're showing signs of inhibition or weakness functionally. That would actually be an indication to just hold your nerve a little bit and tread water, versus push them through and ignore that good clinical information and potentially put them in a situation where, they're suddenly exposed to a plyo activity that is too much for them, and bugger me, they have an exacerbation or a re-injury.
Most definitely. You're letting the training be the testing as well. And I think it's beautiful. I think there's obviously times and places for deliberate testing of specific capacities, of course. And I don't think that either one of us are negating the importance of that. But I think that it's also great to see that there are nuances that you're kind of creating this continuous emphasis training model, right? As soon as you kind of fill up one bucket of need to a certain degree, then that bucket can kind of overflow into the next. And so you're still prioritizing certain areas. However, it's not necessarily like you're just tossing one thing completely away.
Yeah. Yep. Great. Well summarized.
One thing that I really want you to kind of discuss before we wrap things up is I remember hearing you discuss the idea about return to run with respect to ground contact times and how that influences from a calf injury perspective. Can you just give the listeners a brief synopsis as to kind of how you use the idea of either minimizing or maximizing ground contact times when introducing running for individuals suffering from a calf muscle strain injury?
Yeah, great question. And I guess, this leads on really well from our recent chat regarding being really comprehensive with our processes involving strengthening, horizontal strengthening, our sort of pseudo plyometric activities into our true plyometrics. And really, if we've done that and taken the time to do that, we should be very well prepared for elementary run prescriptions. And certainly with some of the harder plyometrics, those would, for argument's sake, be more demanding than elementary run prescriptions. So I want to emphasize that, with all patients, it's not necessarily a situation where you have to make them do the hardest plyometrics you can sort of prescribe before you let them run. In a patient where they've had repeat recurrences, stubborn problem calves, you'd certainly want to be more comprehensive and do some of the targeted testing that you're talking about to make sure that you are getting similar outputs between sides before you run them. But if we talk about just a run-of-the-mill low-grade calf strain, I guess if you've got that level of confidence from their strengthening, from their plyos, you would do a return to run clearance test as well, which has 3 primary arms. Okay, one is the resolution of basic clinical signs and symptoms. So they need to have normal range of motion and tissue length and extensibility with bent knee and straight knee stretching. They need to have normalized repeated force generated capacity with their body weight calf raises, metronome paced. They should have an acceptable level of isotonic strength, okay, that you're happy with, which can vary between sports and also resistance training history. So you might need to come up with a clinical number there. But if you were to test it isometrically and get like an MVIC, they should definitely be pushing over their body weight for a run-of-the-mill calf before you let them run for the first time, the evidence would suggest. And I will say as well, for a recurrence or a problem calf, you might ask them to be doing twice their body weight at a minimum before you let them run. And then you need to get them to do a plyometric test. Okay. Without technology, really simple test is to do a repeat hop test on the spot, where you might ask them to do a number of repetitions, e.g. 15 to 20 submaximal hops on the spot, letting their knee flex and extend like they would, and their ankle dorsiflex like they would during the stance phase of running. And they should demonstrate A, capacity to do it, but B, tolerance over time, and they're not getting progressive symptoms, which is especially important for soleus injuries. But then I'm also an advocate, and Nick Kane and I have talked about this a lot, of doing pogo testing. Okay, so knee remaining straight, moderating that force and producing force at the ankle, where you're really calling upon the calf Achilles muscle tendon unit to be doing the work, and you might get the person to show you that they can do 20 single leg pogos on the spot. A, capacity to do it. B, no progressive symptoms. And C, no hangover symptoms after they've done the test, e.g. tightness, soreness. So after you've worked through that testing battery and you're like, yep, based on this, based on the rehab process, I'm happy that you're ready to run. A theme we identified within our research is that first return to run prescription is important and should be controlled. Historically, clinicians would find that they'd say to patients, yep, you're ready to run, go and jog for 5 minutes, go and do 10 laps of the oval, something like that might be okay for, say, a low-grade medial hamstring strain, for argument's sake. But we know that jogging at those slow speeds is still very high calf work demands, particularly soleus work demands, really, where you're going to be required to produce and moderate forces that are multiple body weights easily, even at slow running speeds. And so if we also, in those plodding type running prescriptions, have, really long ground contact times, where the time under tension for the calf muscles is theoretically longer, where the patient might be going into more weight-bearing dorsiflexion and therefore greater tensile stresses through the contractile and the elastic elements within the calf. So you add those 3 ingredients together, that could create a situation where people are more prone to recurrence early if you don't control that early run prescription. So what we found, just to mitigate the risk, is that it could be more valuable just to do some controlled run-throughs, okay? We're still not asking the person to run fast. We understand that with fast running, there's still really high peak forces for your calf muscles. But it's perhaps a scenario where, you're trying to get a nice balance between not letting them plod, run for too long, fatigue too much. You're not letting them have these, extensive ground contact times that increase the time under tension and tensile stresses. You're talking to them about, okay, we're doing a 60 meter or 80 meter run through at a, albeit relatively slow but self-selected type pace, with passive rest between repetitions initially. And certainly clinicians that we chatted to within the qualitative paper, for a calf that you're monitoring closely, a first run of 2 sets of 6 to 8 reps of 60 meters with passive rest in between each repetition, that might be appropriate, versus saying to a patient, jog for 5 minutes continuously or jog for 10 minutes continuously. There's nuance with how you can prescribe. You can talk to your patients about time and getting them to do timed jogs, which is definitely reasonable. But I guess what I'm describing is just trying to put mechanisms in place where you control the prescription and you have a really clear understanding about what you're asking the calf to do and the requirements that are imposed upon the calf, versus more ad hoc approaches.
Most definitely. It's a perfect example of, controlling the controllables in terms of measuring and understanding the constraints with which you are giving the individual, and then making sure that you're able to manage that and iterate over time. And I just found it very interesting just because, as I had alluded to at the beginning of this podcast, the calf musculature is just an inherently like a black hole in my head in terms of my ability to manage it. And I think a lot of times when I compare it to other things that have a lot more evidence just as a whole, like something like the ACL, a lot of times people will start out with longer ground contact times so that they have greater amounts of time to dissipate forces, so that there's not as high of that force time curve, that steep impulse generated. And so I just found it to be very interesting to hear almost the argument for, again, a different injury, but doing the exact opposite. And I thought that was quite interesting, just to say, well, if it's a soft tissue based injury and we want to immediately sort of minimize the excursion and the extensibility of this tissue under load, well, then we might want to minimize those ground contact times to ensure that. And so I just thought that was very interesting and definitely opened my mind to a bunch of different methods of selection from a plyometric progression and things like that.
Yeah, well said. And I think it's worth mentioning too that sometimes for the calf, it's perfectly reasonable if they do need to run a little bit later compared to other common lower limb muscle strain injuries. So for the calf, you might give yourself more time to, say, develop all of those qualities that I described, and be happy and confident that you've done that and that they're well prepared for running, so that it doesn't burn you if you pull the trigger too soon.
Definitely. Being a little bit more conservative can always help. So kind of wrapping things up here, Brady, first of all, I just want to thank you so much for your time and the wealth of knowledge that you've shared to myself as well as the listeners, just because I think this will be a very helpful episode for a lot of different people that work with elite athletes that suffer from these types of injuries, just because, as you've alluded to, there is this paucity of research in this area. Knowing that our audience is a group of listeners that are generally within the sports science realm, the strength and conditioning realm, as well as rehab, in your opinion, who do you think we should have on next on the podcast?
Gee, you've put me on the spot. Um, I jump straight to my professional biases. So I'm very lucky to work with some very, very good clinician researchers. If you could twist Tanya Pizzari's arm into being on the podcast, she's an expert in many areas. She would be fantastic. Of course, the tendon crew as well. So Ebony Rio or Miles Murphy would be others to consider. So there's three.
I love it.
Does that sound okay?
I'll take as many as I can get, but 3 is perfect. I appreciate that a lot, Brady. I'll be sure to try and get as many of those as I can on the podcast.
Thank you very much for having me as well.
Yeah, of course. So, Brady, how can others try and get in contact with you, reach out, or just stay up to date on the latest research that you'll continue to be putting out?
So I am on Twitter. If people would like to connect that way. I've also got my institutional email, so brady.green@nd.edu.au. If people have questions or would like to touch base or are interested in research. Yeah.
Awesome. Well, Brady, thank you so much for being on the podcast, and I'm looking forward to the future works that you continue to put out.
Thanks very much.
Right on. And there we go.